Okay, I think we'll get started because I was just waiting for Bettina. I don't know whether she's already on.
Yes, I am.
Oh,
Hi.
hi. Hi, Bettina. Great.
Sorry, I'm a bit late.
Yeah, no worries. I'm happy that you could make it because I know that you have been busy. So welcome everybody to today's Cardiovascular MR Journal Club. And there are a few things before we get started. I try to make it as short as possible. So first of all, I want to officially introduce and welcome Bettina Bessler. Bettina is a radiologist who with a special interest in cardiovascular MR. She's originally from Germany, but maybe Bettina, you can briefly introduce yours very briefly where you are and what you're mainly doing. And Bettina will be from today on will be the co-host of the CMR Journal Club. So she will basically represent mostly European work, whereas I will look for mainly North American work. So welcome, Bettina. And I don't know whether you apparently do not have video, but maybe there's at least a picture of yours. Maybe you can briefly introduce yourself, where you are and what you're mainly doing.
Try to get my video running. So yes, bit light problems here. Yeah, thanks very much. It's really an honor to be able to co-host this webinar series where I also had the honor to present a paper, and I like the format very much. So yeah, I originally am from Germany. And I moved to Zurich, yeah, about a year ago, while my family still is in Germany. So I'm also commuting every time. And yeah, so my interest is cardiac MR and stuff like AI. So yeah, I'm happy to contribute to this. Thank you.
Yeah, no, thank you very much, Bettina, for co-hosting that. So Bettina has done some great work on advanced signal intensity analysis in cardiac MR, and so it's a pleasure having you. And we may have in the future also someone then representing the Asian Pacific, but Bettina, you will be basically the flagpole in Europe. So for those of you who do not exactly know how this works, so and I don't want to steal too much time. So the papers will be presented in roughly 10 minutes, walking just through the PDF by the authors, just saying, okay, this is what we did, this is the problem, this is what we did, this is what we found, and this is why we think it matters. Then we have a period of discussions. You can, during that time, either unmute yourself. So I hope everybody is muted now, but so then unmute yourself in the question period and just ask questions. But in case you come up with questions at any time, you can always type them into the chat box. So on the bottom, there's a button for chat, and then leave your question there. And then I will ask them on your behalf. So we walk through that paper 10 minutes, and then you have a few minutes of discussion. And so it's half an hour, 2 papers. So today the topic is strain, and strain has been around since many years. So ECHO already did a lot of work on strain, and people typically perceive it as a kind of a function analysis on steroids because we get an information on function basically per pixel. That's the good side. The bad side is that methods have varied a lot. Parameters, there are several parameters out there, several software solutions out there, different reports on accuracy and reproducibility. So it's still an area which looks like it would be still evolving. And therefore, it's important to have good and solid papers. And today we have 2 papers on that topic that I think are worth discussing in a little bit more detail. And so I'm thankful to the authors, Kady Fischer and Christoph Graeny for the first paper, and Florian von Brengendorf, or Brengendorf. I always get these because you have 2 names, so von Knobelsdorf, Brenkenhoff. So Florian for the second paper. So the first paper will be presented by Chris Graeny, and it's called Feature Tracking Myocardial Strain Incrementally Improves Prognostication in Myocarditis Beyond Traditional CMR Imaging Features. So that's important because prognostic value is one of the key features we want to we expect from a good diagnostic modality. So Chris, take it from here, and thank you for coming.
Yeah, thank you for the introduction, Matthias, and also it's a great honor for me to present this work here in this very nice format of this CMR Journal Club. And yes, I would like to talk about our paper about feature tracking myocardial strain in CMR in myocarditis patients. As we know, making the diagnosis of myocarditis is not very easy based on clinical features. Patients present with different symptoms and signs, and also sometimes they have troponin, sometimes CRP, sometimes not. ECG is challenging, etc. And the invasive biopsies used to be the gold standard, the Dallas criteria, but the problem is that we have the problem of sampling errors, and nowadays with CMR we can really now characterize the tissue and get the information of the whole myocardium and make the diagnosis based on the Lake Lewis criteria, which have been published in 2009 in a nice JACC white paper, and in an updated version 2 years ago. This is just about diagnosis, but my interest was, can we also use this information from CMR to make a prognosis in such patients? And we published a couple of years ago that in patients with clinically suspected myocarditis, that LG presence and also LG size is a very good prognostic marker. We also could show that ECV is a prognostic, and then from that on, we thought, is there more information in CMR images? And we thought maybe feature tracking myocardial strain, which we can just perform post-processing to the CINA images, might give us a better idea of the function of the myocardium than just the very rudimental LVEF. And then we therefore performed this post-analysis on these images. So we used a retrospective cohort from Boston. So actually those were, I can just maybe open this Word file. Can you see it? So a total of 744 patients over a period of over 10 years were clinically referred for exclusion of myocarditis. We excluded patients who did not meet the ESC and AHA diagnostic criteria for myocarditis. Also excluded patients who did not have any LG or T2 weighted imaging. And then at the end, we said that patients had a highly likelihood of a myocarditis based on LG and or an T2 enhanced images. So at the end, we got quite a big cohort of over 450 patients where we performed CMR feature tracking. So feature tracking is, maybe I can just show it on an image. So you basically take the short axis, the long axis images, you put an endocardial contour, epicardial contour in systole and diastole, and then you can look how the myocardium is moving. We then associated these findings with outcome. We had a total of 16% of MACE and over a follow-up of 3.9 years, and we could show that on one side, LVF, of course, is an outcome predictor, but also CMR FT global longitudinal strain, circumferential strain, and also I just forgot the other strain, was all associated with outcome. Then we made a multivariable model, just first with clinical variables. We selected age, sex, body mass index, and the acuteness of symptoms. Maybe I can just show this here. This is the clinical model. And then compared this to a clinical model plus LVEF and LG percentage, and we could show that there is an incremental prognostic value. When we added on LVF, LG size, the global longitudinal strain, we could show an even better outcome prediction. So we have a independent prognostic value of the global longitudinal strain in patients with a myocarditis. So this is somehow, I think, important because we have already the images. It's something which is contrast-free. Of course, it's only associated with outcome. It does not give us information of the diagnosis. So the big question will be whether this should be implemented in future diagnostics and prognostication of patients with clinically suspected myocarditis. So that's basically what I wanted to tell you. If you have any questions, then just let me know. Maybe I can show here the Kaplan-Meier curve. You can see here when you dichotomize by minus 13.1% the GLS, then you have a worse outcome. And the dotted is the unadjusted, and the solid lines are adjusted. Adjusted means adjusted to age, body mass index, acuteness, and LG extent. And I think it shows that this is a really has a high potential for future prognostication, not only in CID patients, which is already known, but also in patients with myocarditis.
Okay, thank you very much. In short, strain seems to provide additional information beyond and above tissue markers. So that is very, let's say, very helpful to know. The strength of CMR, the main strength is that it is a very versatile method. So you can look at the tissue and function at the same time. So if you can show that there is added value, that makes this method, of course, even stronger. So there's a question from Dr. Raffi from Montreal asking, when did you do the strain study, in the acute phase or during follow-up?
Sorry, I just didn't hear it because I was just disturbed. Yeah, again.
Yeah. So the question was when you performed the strain study, in the acute phase or during follow-up? The strain analysis, is this from images during the acute phase?
So about half of the patients were acute. What we say, they had symptoms below 2 weeks, and maybe half of the patients, what we called chronic, had symptoms already ongoing for more than 2 weeks. And the strain was then done in these images, but of course this is a retrospective study, so we acquired these images quite long ago. But it's quite a mix of acute and chronic. So that is, of course, something which would be nice to go a little bit deeper, whether in the acute phase, the strain has maybe a different prognostic value compared to patients with chronic myocarditis. Indeed, that's a very good question, yes.
Yeah. And then another question from Nilesh Guger from Toronto. What strain software was used? There have been differences reported across different vendors, particularly for the variability of measures.
So I think there is a great variability between vendors. That's actually true. So that's why we stick only, of course, to one software. And in this case, it was Circle CVI42. And what I have to mention is at the beginning, so that took Kady and our students more than a year to do the strain analysis in all these patients. At the beginning, it took us maybe 1 hour per patient, so it was really intensive. But during the course, CVI42 released a new AI button, which helped us a lot. So that helped us doing the contours, and we didn't have to correct that much. So that is something which will improve as well. But of course, the absolute values are maybe not interchangeable with other vendors. So I think we have to keep that in mind.
That's what I mentioned in the beginning. So it seems to be an evolving area, just with T1 mapping, where we also have variations between MRI systems, field strengths, sequence, and software solutions. So another question from Mona Saleh from Kiel. Which kind of software, we already answered, but what was the temporal resolution of the cine images? Because that is the critique of strain imaging, because strain in echo has a higher temporal resolution, and sometimes the question is, okay, can we really get the peak with a temporal resolution we have?
I mean, that's also a little bit a problem when you take images from over 10 years. So the protocol was not always unique. Also, how many phases, etc. So that is something which varied a little bit in this cohort. So the strength is that we have a lot of patients, but of course it was the setting was not always the exact same in every patient.
Okay.
So.
So yeah, confirmative data would be nice, but just to make it clear, so you did not perform a specific sequence for that, but you used cine images as they were acquired by SSFP probably, right? So
absolutely correct. Yeah,
okay.
Absolutely correct.
So then there's another question from Dr. Rafi from Montreal. Have you noticed any correlation between late gadolinium enhanced percentage and impaired strain? Did you analyze something like that?
That's actually something we are planning to do. Also, especially we want to correlate whether there is a difference between longitudinal, circumferential, or radial strain with regard to, especially in this cohort, epicardial LG. So the hypothesis could be that it might be different correlation from CAD patients with the different strain patterns compared to myocarditis patients who have the LG in another part of their heart compared to the other strain patterns. So we haven't looked into that too much. I just wanted to say these patients, almost all of the patients had LG. So if you go one step back to say we look only at clinically suspected myocarditis, it might be that you get another correlation of LG with strain. So I just wanted to mention that because in this cohort, where LG was one of the inclusion criteria, makes LG size as a prognostic marker a little bit weaker. Because it's already in the inclusion criteria.
So in the interest of time, Chris, thank you very much. We have to move on to Florian's paper. So if you could please unshare your screen so that Florian can share. And while Florian is setting that up, so Florian's paper has been published in, Chris' paper was in JACC Imaging and Florian's paper is in European Radiology. It's called Influence of Contrast Agent and Spatial Resolution on Myocardial Strain Results using Feature Tracking MRI. So, so again, we're looking at strain, and in this case, it's, okay, does contrast agent have any role in that, be it positive or negative? And that's also an important question when it comes to operationalizing strain imaging in MR. So Florian, thank you for joining from Agatha Ried in Bavaria, and take it from here.
Yeah. Hello, everybody. Hello, Matthias. Again, thank you very much for inviting me. It is a great honor that you have selected our paper.
Oh, you're muted now, or your microphone is off. There was a little noise and then you were all of a sudden silent, as if your microphone would not be connected anymore. Are you back now? No, not yet. Oh. Now your video is off, but we still don't have your audio. And I don't think you're muted because I don't see the mute sign. So it must be something physical with your microphone or your headset or whatever. Maybe it is disconnected. Florian, are you?
Hello?
Yeah, now you're back. That's great. I hope it works. You were back, and now you're again not audible. So maybe while Florian is doing that, I had one more question, Chris, to you and to Kady. If you compare the different strain, so especially longitudinal and circumferential, longitudinal more addresses the subendocardial layer, and whereas the let's say the circumferential would be more the mid layer. So did you see any, let's say, how would you see the value of the circumferential versus the longitudinal strain, and in myocarditis and in general?
I mean, it's a very good question. And in most cardiac diseases, only the longitudinal strain is reported or was reported as the most predictive value.
Yeah.
And that was also interesting. Also in myocarditis patients, it seems that the longitudinal strain is maybe the best. And I think it also has to do that the reliability, the reproducibility is the greatest with longitudinal strain. So we don't do much of errors when we reproduce it, and that might be something which might influence in circumferential radar strain. If we get better there, then it might be that we can differentiate the different layers according to strain. But in our study, we saw that the longitudinal one was the best.
Yeah. No, that's also sort of the experience we made in Heidelberg and also in Montreal, that the longitudinal strain is a little bit more robust and also seems to be sensitive to ischemic and non-ischemic, to the stiffness of the ventricles, especially, of course, highly pathological in amyloid. And yeah, so Florian, are you back? I see that you have dialed in, but I cannot hear anything, although you're not muted. Now, maybe? Florian?
Hello, can you hear me?
Yeah, great. Yeah,
okay.
Now you seem to be back. Great.
I'm very sorry. It seems to be a problem with the Wi-Fi. I hope it works now.
Yeah. Okay. So
okay, let's speed up.
Quickly through that paper.
Yeah, quick. Thank you again. And spatial resolution on strain results using CMR. I will quickly lead you through the paper. You all know that methods have been developed to analyze myocardial mechanics in more detail. And one of these methods is Cmr Feature Tracking, which uses steady-state free precession cine images, which are usually the same as those for cardiac chamber assessment. And these images are post-processed by dedicated software. The software usually detects or tracks myocardial motion, and then systolic and diastolic strain can be calculated. Cmr Feature Tracking has attracted much interest during the last years, as no additional imaging is needed compared to tagging, for example, and as software has been developed, which is much more faster than in the past. However, there are no official standards about image acquisition, post-processing, and reporting until now. So we aimed at adding a little bit of information regarding standardization. So we analyzed the influence of spatial resolution and contrast agent on strain results. And for that purpose, we included 75 patients. These patients were all in sinus rhythm, and we had two groups. Group A consisted of 50 patients who were quite normal ejection fraction, no wall motion abnormality, no scar. And the second group comprised 25 patients, and they had evidence of infarct-like scar in at least one myocardial segment in the midventricular segments. All underwent CMR at 1.5 Tesla. We have a GE scanner here. And for the feature tracking analysis, we acquired cine images in 3 variants. Variant 1, standard cine, native, spatial resolution 1.4 times 1.4, and the temporal resolution about 40 milliseconds. A second variant was native cine, but with lower spatial resolution of 2 times 2 times 8. And finally, a third variant, which is a contrast enhanced cine. So we acquired the cine images 5 minutes after administration of dotarem. The images were analyzed using CMR 42. For that purpose, the endo and epicardium were delineated in the cine images in a 4, 3, and 2 chamber view and in a short axis view. And then the software provided the contours, which then were adapted manually by experienced CMR readers. This study focused only on the peak systolic strain, not the diastolic strain. So we only used the peak systolic strain in longitudinal, circumferential, and radial direction. For the participants of group A, we assessed the strain both per segment in the midventricular slice, and also we calculated a mean value. For group B, it's a group with the infarct. We only focused on the segment where the infarct was evident. Just one explanation which sometimes leads to confusion when reading strain studies. Strain is defined as a change in length of an object within a certain direction relative to its baseline length. As the systolic length is smaller than the diastolic length regarding the longitudinal and circumferential direction, the strain result is a negative number. And this negative nature can lead to confusion when describing increases or decreases in strain. So we followed recommendations and we specifically mentioned the absolute value. So an increase or decrease of the absolute value of strain. Can you still hear me? Okay.
Yeah.
Okay,
Yeah.
just to be sure, because I have some trouble with the internet here. Okay, so let's move on to the results. I will first present the results regarding the influence of spatial resolution and then regarding the influence of contrast agent. In this table, you see that in group A, lower spatial resolution led to a significant increase of the longitudinal strain, and in group B, the lower spatial resolution also led to a significant increase of the longitudinal strain, the circumferential strain, and the radial strain. When we look at the same results but illustrated with all single values shown, again we see that for group A, lower spatial resolution led to an increase of longitudinal strain, and in group B, lower spatial resolution led to an increase of longitudinal and circumferential and radial strain. But you also see the wide range of single values and the high inter-individual variability of the strain results, which certainly is one of a possible limitation of the method or of the study, and we can discuss that later. If we then look at the values per segment in group A, the longitudinal strain became higher with lower spatial resolution in the anterolateral, inferolateral, inferior, and interoceptal segment. Now, what about the influence of contrast agent? Here we see that after contrast agent administration in group A, the circumferential strain decreased significantly and the radial strain decreased significantly, while in group B, the contrast agent did not lead to a significant change of the strain results. And again, if we look at the images, at the results, the individual data points, we see the significant change of circumferential and radial strain in group A with gadolinium. But again, we see that there is a wide range of values which we measure per individual subject. Finally, again, the segmental values after gadolinium, circumferential strain changed in the anterior and anterolateral segment significantly, and radial strain also in the anterior and anterolateral segment and in the inferior segment. So just to sum up again the results, we see that lower spatial resolution changes longitudinal strain, and leads to elevated longitudinal, circumferential, and radial strain in group B, and gadolinium led to reduced circumferential and radial strain in group A. So we had some thoughts why we could observe these changes of strain results. Of course, we have no proofs, we just can introduce hypotheses. So generally, optical flow, which is one of the algorithms used for strain analysis, determines motion by tracking and detecting the displacement vector of the different signal intensities and image features as they move throughout the cardiac cycle. And we thought that a lower spatial resolution, so larger pixel size, may influence the segmentation as well as the algorithm, eventually leading to different strain results. So we assumed that a lower spatial resolution only recognizes larger displacements compared with higher spatial resolution. And this would be in accordance with our findings because we detected an increase of longitudinal strain with larger pixel size. Another aspect might be partial volume. Partial volume effects might be another influencing factor. The vicinity of the endocardium is often trabeculated, containing blood and deforming different than the compact myocardium. Furthermore, the motion of the blood itself may affect tracking near the endocardial border. And when reducing the spatial resolution, as it has been done in this trial, the border zone endocardium blood may have become less sharply defined, and by this promoting differences in strain results, independency of the pixel size. So partial volume effects might be one explanation. Furthermore, regarding the contrast changed by dotarim administration, the alteration of the circumferential and radial strain results in non-infarcted myocardium associated with the administration of contrast agent may be explained by limitations in differentiating the border between myocardium and blood, which becomes more difficult in contrast-enhanced images. Generally, the differences we detected were very small, so these are not very large changes. Nevertheless, they might be important because when other studies use strain to differentiate normal and abnormal, the differences often are also very small. So, in conclusion, we found that both the variation of the spatial resolution and contrast agent influenced strain results that were obtained with feature tracking. So we think that standardized image acquisition is important to have reliable and comparable measurements. We recommend to use cine images before giving contrast agent and with a constant and reasonably high spatial resolution. Thank you very much for your attention.
Thank you very much, Florian. Before continuing, and I want to mention one thing to disclose, I'm involved in software development specifically for circular cardiovascular imaging, but the selection of these papers was by no means in any way dependent on that. And I would just want to mention very clearly that there's other software out there that can be used for strain evaluation. There's software that uses specific sequences like fast strain or FSync and dense imaging. And there are also other techniques that use cine images. And there are software companies like Tomtech and Medis that also offer strain analysis. So this is nothing exclusive to CVI42. Just wanted to mention that, and then to make it clear that this is not is by no means supposed to be in any way biased. So what we're talking about here. So thank you very much. So in your conclusion, you said it's about standardization, but is there any of these that you would prefer? So you said high spatial resolution, if possible, at least consistently high, and before contrast. And then the same question to you that I mentioned before. Is there one of the strains, radial, longitudinal, circumferential, that you would prefer based on the current body of evidence? So which one, you're a very clinically oriented CMR expert. So what would you use, or what do you use for your patients?
So to be honest, in the clinical routine, we do not apply SYN imaging for strain analysis, but based on my scientific experience and and the literature, I would prefer longitudinal strain, because I think it's the parameter where we have most experience, and we have comparability towards echocardiography. So I think this is at that moment the most promising parameter.
Yeah. So that echoes what Chris Gaini had said before, and what I also could echo, that maybe currently the evidence we have supports the use of longitudinal strain imaging, especially when using features or tissue tracking methods. Now, FSENC is using a different approach. They directly measure basically the deformation or the change of the location of pixels. And DENSE does something similar. They need specific sequences for that. But this is how it currently looks like. So maybe a question to both of you before we conclude. Do you think that we will use strain imaging in the near future, or do you think we need significantly more additional evidence and studies? Chris and Florian.
Maybe I start. So it's difficult to answer this question, because just when I compare with echocardiography, that strain is available there since many years, and in clinical practice, it is still used quite rarely, as I experience it, to be honest. So it takes a long time until a method is really applied in clinical routine. But I think we are on a good way to establish this technique, because with feature tracking, we do not have the obstacle anymore to have additional images that we need hours for post-processing. So I think from the technical point of view, there has been done a large step during the last years. And I think this is a very good prerequisite to now establish it in clinical routine. But I think we should mainly focus at the moment on one parameter, for example, like longitudinal strain, and try to imitate the things that they do in echo, because that might help to get clinical acceptance.
I completely agree with you, Florian. And I think also time is crucial. And when AI is helping us a lot doing the contours, and we are getting with 3 clicks a very nice GLS, then I think that can be easily implemented in clinical routine. And also for the right ventricle, I just want to mention that in a second now. The potential is huge, because in echo we don't have very nice images from the right ventricle. I think their CMR has really great potential as well for the strain imaging.
Thank you very much. Bettina.
Yes, I had a question to Florian, so which is actually in line with what you said right now, that AI might help, especially with these reproducibility issues we commonly encounter with feature tracking stuff. So I want to ask you if you did correct for reproducibility problems, because I'm wondering if these differences you have reported might also be, at least in part, due to reproducibility problems.
I completely agree with you, and this is also the reason why we really concluded cautiously in this paper that we found some changes, but of course there might be other influencing factors that can produce these strain changes, like observer dependency and scan-rescan reproducibility. So in this study, we could demonstrate that our observer dependency is quite low, But of course, you are totally right that the changes may be in part also explained just by a issue of reproducibility. We did not correct for that in that study.
Okay, so that's why we need AI for our strain contours.
Yeah.
Yes.
Yeah, I think that's what we learned, that more and more we understand that we can do a lot, but in the future, probably most of what we do will somehow be influenced or even dominated by AI. And so it's very important to embrace this technology and in a guided fashion, make this part of what we're doing. Okay, thank you very much. I'm very sorry that we went over time today. So thank you very much for joining. Florian, if you could unshare your screen, especially thanks to Chris and Kady and Florian for joining. And the next journal club, there is also the JCMR Journal Club. I want to, you find that on the SCMR website. There are also webinars. The next CMR Journal Club will be on October 7. And we will have two interesting papers. One is on diastolic function, published in JACC Imaging by Martin Ugander's team. So how to assess diastolic dysfunction and comparison with echo. In patients with diastolic dysfunction, and then a paper by Thomas Küstner and the team from King's College about a very exciting new reconstruction technique that allows a very fast reconstruction of cine MRI in 4D. So October 7, and Bettina will host that, and I'm already looking forward to that. And so want to thank everybody here for joining tonight, and wherever you are, I wish you a good afternoon